Well, like I said, I am Christina. Hold on, my slide. There we go. A little bit about me. I've been in the veterinary field since 2006. I have been part of AVES since the very, very beginning, 2014. I actually just celebrated my 10-year anniversary with AVES earlier this month. And then up until June of last year, I was the operations manager. And then I transitioned into the community and working as the AVES relationship manager. So you can see in these pictures that I have 2 kids and 3 dogs. So we work out to be 3 boys and 3 girls, and we keep everything very balanced, or we try to at least. So the role of the relationship manager is really to work with you to make sure that y'all are getting what you need from AVES as a hospital. If you have any questions about any of AVES processes, I have been highly involved in building most of them, and try to stay in tune with what's happening in the hospital, so can answer most of your questions during my visits. And if I don't have your answer, then I definitely will work with my medical director and the leadership team to get answers for you. So if you ever have questions, comments, concerns, or want to know what services we have, anything like that, if you want a lunch and learn to help with development of your team, we have a whole list of topics that we have ready to come to bring to your team. If there's something that we don't have on that list that is of interest to you, or you think that there's a need for, then we will build it for you and come work with your team. And then also, if you need any more of the AVES materials to give to your clients, or to help as references when you're talking about different disease processes. And you can always reach me at christina.bingham@austinvets.com. AVES is a robust emergency and specialty hospital. We have currently our services are emergency and critical care, neurology, internal medicine. With the addition of Dr. Slead, we've also added interventional radiology, which we're super excited about. That's new to AVES and pretty new to Austin as well. We have diagnostic imaging, surgery, oncology, and we partner with CVCA for cardiology services. AVES is expanding, and we're very excited about it. Dr. Slead will gain a partner the third quarter of 2024. I know a huge issue in the community is the caseload for internal medicine, so we are doing our best to try to grow our internal medicine team to try to help with that need. We will be opening a new hospital in early 2025 with the new building. The new building will be very close to our current facility, just a mile away from where we are now on 360, closer to 183. And with that, we will be adding radiation oncology, and we'll have an anesthesia department. Our anesthesiologist is Dr. Whitaker, and he will be joining us in 2024, but we'll have a full department by 2025. And then based upon the needs of the community, we are very hopeful and actively searching to add ophthalmology, dentistry, and dermatology. Dr. Slead will be presenting tonight. He received his doctorate of veterinary medicine from Kansas State. And then he did a small animal rotating internship at Purdue. And then he also performed a residency and a fellowship in nephrology and urology, both at North Carolina State. Dr. Slead, are you ready to take over and start jumping into the subject topic?
Yep, sure can.
All right, thank you.
So, like you said, my name is Tanner. I just started here at AVES back in September after my NU fellowship. It's kind of an exciting time for NU. The College of Nephrology and Urology just got accepted in 2023, and I'm currently in the inaugural class for the first residency, so that should be done by either later this year or early next. But I think it's really important because we've got so many cool new things that we can do specifically within the NU field in vet med, and I'm going to be focusing specifically on urolithiasis, primarily with in regards to, you know, once we find the stones, what do we do next, and kind of some of the new options that we have available for us through AVES. I'll start with dogs, and then I'll go to cats next. These are two separate lectures because the goal is to have these uploaded on the website. So if you ever need to refer back to them, you can at your leisure. And then I think just in general for any of these cases, I'm always down to talk about them, but they're always all a little bit different. And so if you ever need to consult, I'm happy to do so. And so a lot of this information comes from the Small Animal Consensus Statement about uroliths that came out in 2016, which most of it still holds true. I think the biggest change is just that a lot more people have access to this equipment, and a lot more people have the expertise for mostly the minimally invasive approaches. And so I always start, and this will be the first question that I ask anyone if there is a question about referring or consulting or what have you. There's basically a couple or a few things that we need to have for every case where we're going to try and figure out what is the best way to approach stones that have been diagnosed. First and foremost is a urinalysis, basically just to kind of help us figure out, based off of the pH, based off any sort of crystalluria, you know, what kind of stones might we be dealing with. Importantly for that, especially if there's concern for struvite urolithiasis, we're going to want a culture to see what bugs are growing. And then more important for me, especially in regards to our options for removal, are going to be abdominal radiographs. There are obviously caveats to this, like with some of the stones that we can't see or aren't as radiopaque. But basically the question that we are trying, or I am trying to answer, is the size and the number of stones, in addition to the size of the animal. And so, especially if this is a male, the easiest thing that you can do to know if anything minimally invasive is possible is to pass an 8 French red rubber catheter. That is the size of our flexible, it's a ureteroscope for humans. We use it as a urethroskope in dogs. That's the smallest size that we have. So if they can't fit an 8 French red rubber, we already have our answer in regards to whether or not we can safely or easily remove these things via scope. Females, it's a little bit harder, I'll be honest. Usually the cutoff that you'll find, like if you look this up, is that they need to be at least 5 kgs. I've definitely scoped smaller than that before. The difficulty or the caveat with that is that if they're around 5 kgs, sometimes I won't know if I can fit my smallest rigid cystoscope until they're actually anesthetized and until I actually try and pass it, because every small dog is a little bit different. But again, this is kind of the baseline that I think will help inform any sort of consult or any sort of conversation about what we need to do next. And so I'm just kind of going to work my way down the urinary tract. So we'll start with nephroliths. I get a lot of referrals for these. And generally the owners are coming to me with this idea that they need to do something about these nephroliths. It would be awesome if we could, but the fact of the matter is we just don't have the same ability to address nephroliths as humans do. And that's primarily due to size and anatomy. So essentially the goal for nephroliths, or the recommendation for nephroliths, is only to address them if they're quote unquote problematic. And problematic is described as either obstructive, painful, or the nidus for infection. Obstructive is exactly what it sounds like. We're going to be looking for things like hydronephrosis, proximal hydroureter, relative azotemia, and hyperkalemia. As I'm sure you guys all know, it's usually not that simple, especially so in cats, which we'll talk about in a second. For a lot of these animals, especially for the nephroliths, they kind of like to jingle around in the pelvis, and that means that maybe they're only sometimes obstructive. So it's sometimes hard to make that decision. But obviously, if they're very painful, or if they're having recurrent infections, or if that stone is taking up a lot of the pelvis, we're going to want to do something about it. I think it's important to note, though, that in dogs, in contrast to cats, which again we will talk about a third of them are struvites, based off of the most recent retrospectives. And for struvite stones, and for any of the potentially dissolvable stones, we're always going to want to try and dissolve them first. The caveat to that is obviously if they're very large and very obstructive, and we don't think that even if we start medical management, that urine's going to bathe the stone to dissolve it. But again, we can have some ideas as to whether or not it's struvite, right? So if they have really alkaline pH, if they have a UTI, if they have that kind of moderately radiopaque appearance on radiographs, sometimes, again, if they're not obstructive, that will be a time to prioritize dissolution. And I won't go too into that. It's a whole other lecture. But if they are obstructive or if they're really big or just problematic in general, for dogs at least, what we're recommending is minimally invasive stent placement. Same idea in terms of whether or not, as far as who we can place them in, it's basically comes down to size, right? So if a male can accept an 8 French red rubber, then I can get my scope up there and I can get a stent up there. And then same idea with females. If they're greater than 5 kgs, I can probably place a stent minimally invasively. I don't know if anyone will have a question about this, but just to kind of head it off, there is question regarding whether or not we should just place subs in these guys. What I will say is that if we are able to minimally invasively place a stent, that's always going to be preferred because we're always going to want to remove the stent if at all possible. And so again, if I can scope them and place it, I can scope them and remove it even easier. For animals where we're going to have to do an open approach, which I won't go too much into in this lecture, that conversation surrounding stent versus stub becomes a little bit more worth having. But in general, again, for these bigger guys, we're going to try and place a stent. Moving on to ureteroliths, there's a lot of overlap with nephroliths in this case, but usually they're problematic, right? So usually if we find a stone in the ureter, there's at least some degree of obstruction. Again, we're looking for things like hydronephrosis, proximal hydroureter. Lots of times we'll see that kind of periureteral or retroperitoneal inflammation on ultrasound. And then sometimes we'll see some blood work changes. And when I say sometimes, I think that's an important discussion to have too, because especially in dogs, a lot of these dogs will have very functional contralateral kidneys. And as we know, if they have an entirely functional contralateral kidney, they're probably not going to be azotemic because that's enough nephrons to kind of keep that creatinine within the reference range. So a dog can be completely obstructive and still not have an azotemia or hyperkalemia, and that's the importance of imaging. I think it's also really important, and this is probably, again, a little bit more of a cat thing, but ureteral obstructions can be dynamic. And so especially for the kind of polygonal shaped stones, sometimes depending on the way that they're oriented within the ureter, sometimes they're allowing more urine to pass by than other times. So they're not always completely obstructive. But in general, we still know that even if there's a degree of obstruction, so even if there's a degree of some urine backflow, that is causing damage to the kidneys and they're still worth addressing. And then I like to bring this up too, which I learned from a CE last year from a human urologist. And there's this idea that it probably holds true in cats and dogs too, of intra versus extrarenal pelvis. And the idea there is that just depending on the dog or the cat or the human, some of the actual renal pelvis may be more surrounded by renal tissue, and some of them may be a little bit more oriented towards the, I guess, edge of the renal parenchyma. And the reason why that is potentially important is because if they have a more intrarenal pelvis or pelvis and it's surrounded by more solid parenchyma, those might be the cases that aren't going to dilate quite as much as the ones where the renal pelvis have more room to kind of expand outwards if they're more on the kind of margin of the parenchyma. Again, this hasn't been looked at a lot in cats or dogs, but I think it's a good or a reasonable explanation for some of these cases that have minimal pelvic dilation, but we know that they're obstructed. In general, and again, I won't go too far into this because it's a whole other lecture on its own. You can always attempt medical management. Generally, that looks like 1 to 2 days of fluids and tamsulosin or prazosin. Some people use mannitol, some amitriptyline. Based off of the most recent study that I think came out last year, there's about a 50% success rate with this. I think it's hard because these are such heterogeneous populations, and what it really depends on is what type of stone it is. So is it struvite? Is it calcium oxalate? Is it jagged? Is it smooth? And then where is it when you find it? There are studies to say a stone of this size in this location is more likely to pass. I think those are mostly cat studies. But again, like if it's a distal, small and smooth stone, you may not have to do anything beyond medical management and it'll pass on its own. But again, if it's a really large or jagged stone and it's much more proximal, it's probably not going to pass. So back to like what we're going to do about them if we can't pass them with medical management, or if we are pretty sure that they're not going to pass based off of one of the things that I just mentioned. This is another case where we're going to try and place a stent. And so same thing as you'll keep hearing me say, if a male can accept an 8 French red rubber, if a female is greater than 5 kilograms, I can probably place a stent minimally invasively. This is not meant to scare anyone off from recommending this, but it is probably one of the more technically challenging things that we do in endourology. I think it's more of an experience thing, and generally we're going to be successful in getting the guide wire up past the stone, no matter really where it is and what kind of stone it is. But I always, especially just, and maybe this is fear-based of me, but if I'm going to be recommending this, because we're working in a really tight lumen, the biggest risk is that we're still going to have to potentially open these guys up and place a stent or get the stone out surgically. But again, we're getting better and better at placing these stents. And the nice thing about, again, these dogs that we can do it minimally invasive in is that lots of times what will happen is we'll place the stent, and I don't know how many of you have seen the double pigtail stents. I think I maybe go into it after this. They have little perforations all throughout the stent itself. And so urine is flowing through the stent as a tube and then out the sides. And it causes what's called passive ureteral dilation. And so usually what will happen is that the stone will end up being able to pass because the stent simply being in place is going to allow for that ureter to dilate. Again, we like this because overall the morbidity and mortality is super low, so less than 2%, and a really low rate of reobstruction. In addition to rapidly improved azotemia when compared to surgical intervention. That's probably just because we can do this faster. There's less anesthesia involved. There's no incisions that can potentially dehiss or stricture down. So again, if this is an option, it's our best option for all of those reasons. And so again, this ureteral stenting is using one of these double pigtail stents, using a combination of cystoscopy and fluoroscopy. Generally, when I'm talking about it, I'm going to be doing it retrograde, so through my scope. And again, it's preferred over surgery because it rapidly stabilizes azotemia. You're really not risking stricture, aside from where the stone may be lodged. There's no risk of leakage because there's no incisions to heal. And probably because of that, and because of the lack of a risk of stricture, there's a decreased rate of recurrent obstruction. And usually we can actually do this in an outpatient procedure. And so again, a lot of these cases are variable and it kind of depends on the severity there. But if it was maybe an incidental finding or we found it really rapidly, I could place a stent and send the dog home the same day or the next day. The risks are overall low. Like again, so it's minimally invasive. We love it for that reason. The biggest thing again is that inability to place. There are some reports and some studies that look at this, not very many, but the stents can encrust, especially for some of those calcium oxalate formers that really like to have highly crystallizable urine. We'll often see some proliferation at the UVJ, which is usually clinically insignificant. They can migrate. That's definitely happened to me before. If you choose the wrong stent, UTIs are always a risk because that is an implant. And then this idea of forgotten stent syndrome, where you forget that it's placed and you don't remove it. Cystitis is on the list, but it's actually a pretty rare or pretty uncommon adverse effect from placing stents, at least in dogs. And we don't really know why, but they generally tolerate it pretty well. If they do have some cystitis from the stent, I can actually go in and trim it. But this is in contrast to cats, and we'll talk about that again, where cats, they hate stents, they get really awful cystitis, and usually don't tolerate them very well. And again, removal is always going to be recommended when possible, which is easy. And then cystolith. So this is the big one that I'm hoping to really work with our community here in figuring out ways to get these cystolith dogs in and out quickly and easily. And again, that's with a combination of working with you guys and kind of knowing the minimum diagnostics that we need, but then understanding the indications, because I think that's the most difficult thing for anyone to kind of understand about the indications for minimally invasive removal, because again, every case is so different. But in general, we're going to recommend removing them if they're associated with clinical signs. But that is dependent on a few different factors that are variable from person to person that are performing these procedures. And again, generally it comes down to the experience, the equipment, the urolith burden. and the potential for a need for a second procedure. And so again, we're going to remove them if they're likely to cause obstruction. So these are the ones that are smoother, that are a diameter similar to the urethral lumen. And what you can do is you can just measure the proximal urethra on radiographs. And if the proximal urethra looks about the size of a stone, then that's going to be one that we're a little bit more concerned about. But then we monitor if they're non-clinical or if they're unlikely to cause obstruction. So sometimes those really big calcium oxalate stones, they are less likely to make their way into the urethra. And if they're not the ones that cause a lot of cystitis or the dog doesn't seem uncomfortable by them, sometimes we can just leave them. I hedge on this a little bit because even just recently, I've seen a lot of really large stones that I would have never expected to get all the way down into like the penile urethra, but somehow these dogs find a way. And then we're always gonna, again, want to dissolve the stones that are dissolvable. So if is a high suspicion for struvite, if the urine is alkaline, if there's a UTI, if it's a female, if they're moderately radiopaque, if they're low in number but kind of larger in size, we all know what a struvite looks like on radiographs. Those are going to be the ones that we try and dissolve. What I will say, and this is kind of a challenging clinical debate for some of these struvite dogs, and I'm sure you guys have seen this too. There's lots of these little white dogs that have really awful struvite urolithiasis, and the owner just can't give them antibiotics every day for however many months. So sometimes in those cases, depending on the number and size, I'll remove them at the start. Other times we'll try and dissolve them a little bit just so they're smaller and more amenable to removal. But the point being that there's always kind of caveats to whether or not we're going to recommend dissolution or not. And then same idea with why we like this minimally invasive procedure, because it's associated with shorter hospitalization, there's fewer adverse events, and there's generally fewer residual stones. So there's been a lot of studies, especially in humans, to say that just because we have better visualization through our scope, we're much less likely to leave stones in there than compared to surgeons when they're looking just grossly at these tiny little stones, because how could they see within all of those folds? And what else was I going to say? Yeah. And so this is kind of a crappy picture, but I like this one because I think the other thing in terms of why this minimally invasive procedure is preferred when at all possible is because this is an example of suture-associated calcium oxalate stones. So right here is where the dog previously had a cystotomy. And then we know that those dogs that have cystotomies, that have even the tiniest bit of suture poking out into the lumen of their bladder, can form stones right along it. And so usually they'll kind of form on that incision site on the suture, but then they'll fall off and then I'll have to go in and grab them.
Dr. Slead,
This is
before
kind
you
of
move on, we had a
yeah,
question in the chat just asking what was MIP? What is MIP?
sorry, yeah, minimally invasive procedure.
Thank you.
So cystoscopy, yeah. This is a picture that I like because it's just kind of a classic case. So this is a perfect amount of stones. There's 3 of them. They're pretty small. This is a recurrent stone former that I used to scope probably every 8 months or so. And this is just kind of classic. So this is what I like to see. And so this is another table that I like to reference. It's from a Vet Clinics of North America study from 2019. And this is a good thing just to refer back to. It kind of goes through the limitations and advantages of each type of removal, but we'll keep moving on. And so for voiding hydropropulsion, this is one that I get asked about a lot too, mostly from owners because I think it's kind of a confusing word. But the idea here, as I'm sure you guys all know, is that we're using manual pressure and cranial traction of a filled bladder for antegrade removal of small stones. So we're going to fill the bladder with saline, about 10 to 15 mils per kg, but this does have to be under general anesthesia. The risk of this is just that it's simply not always effective. If there's a lot of big stones, we're probably not going to push them out. And then sometimes, and I've definitely seen this, you can cause an iatrogenic obstruction. So you kind of have to be ready for that as a risk if you're going to try it. For females and males, the general cutoff are you're going to want about 3 to 4 millimeter stones in most females. That's about the size of their urethra. Obviously, bigger dogs have bigger urethra, so you can get bigger ones out. That's where it's helpful to measure that proximal urethra. And then males, they're a little bit more difficult, as I'm sure you guys know too. So we're going to want really small stones. Usually the size of the penile urethra is the most limiting, just because right at the level of that os penis, it's going to be a really narrow. But what you can do is you can try and pass the largest red rubber catheter that you have, or that they'll accept, divide that by 3. That's the amount of millimeters that their penile or that their urethra will fit. And if the stones are smaller than that, then it's worth a shot. I think what makes this a little bit more challenging, especially challenging to recommend, especially when you have other equipment, is that you have to find a way to confirm that they're empty after you do void and ural hyperpropulsion. So in most circumstances, if you're doing this, you probably don't have a scope and you're going to have to do radiographs after. Depending on where you're at, that can be cost prohibitive. That's why, in general, if I'm going to do this, I'm just going to have my scope ready so I can go in and look and get a better view right after we do it. But either way, you have the option. But moving into vascular retrieval, and this is the stuff that, again, I'm hoping to kind of lean on or make the community more aware of our options for this, is it's where we use the cystoscope to pass retrieval devices or baskets to remove bladder stones, and this is under direct visualization. Again, this does require general anesthesia, but generally it's a really quick procedure. Obviously, it depends on the size and the number of stones, but most of these cases, they can come in the morning and I can get them out in the afternoon. The risks are primarily involving the, again, size and the number of stones. So there is a potential for a really prolonged procedure time if there's a lot of stones in there. Sometimes I'll even stage them. Generally, if we're in that territory, I'm going to be more likely to recommend just a cystotomy, and then for recurrent stones, when we catch them quicker, do scope. But that's one of the bigger risks. And then kind of in the same vein, the longer that we're doing it, the more likely we're going to cause iatrogenic trauma from ripping those jagged stones through the urethra, and especially in males, the risk of stricture formation. Kind of the same idea with that I keep harping on. For females, we want about 4 to 5 millimeter stones. Males, we want smaller, but really the biggest limiting factor is their size. So if a male can accept an 8 French, I'm usually down to try. And then really the number of stones that anyone's willing to remove just kind of depends on preference. Honestly, if I have a slow day, I'm a lot more likely to be willing to try and remove 20 to 30. If that's not the case, then I'm going to want obviously a less number of stones, just so they're not out for so long. And then laser lithotripsy. So I think also this gets into semantics a little bit. I'm not always going to be doing laser lithotripsy just if I'm doing basket retrieval. So i.e. not all stones that are going to be removed via the cystoscope need a laser to be removed. And so basically what we're doing is we're fragmenting larger stones in preparation for removal the same way. So either with ural hyperpropulsion or vascular retrieval, usually vascular retrieval if we're in there. There's similar indications and limitations as vascular retrieval. But in general, we're going to want a low stone burden, and I'll show you why that's the case in a second. Because there's really a risk for a long procedural time that then outweighs the risk for surgery. And that's primarily because we're breaking these larger stones into a lot of fragments. So a few big stones can turn into 50 small fragments. That's a lot of passing in and out of the urethra, because that's what I'm going to be doing each time I remove a stone. I can't pull the stone through the scope, unfortunately. And so obviously, if I have a laser in there, there's higher risk of lower urinary tract trauma or rupture. You'd have to be sitting there for a long time lasering the bladder to break through it, but it's been described before. And so this is an example. I get a lot of cases or referrals like this. I think when you look at this, it's like, oh, there's only 5 stones. Sweet, you should be able to remove those quickly. Those 5 stones are probably going to turn into about 100, if not more, fragments. And so that's a case where I probably am just going to recommend surgery. That being said, I don't know if you guys would agree on this, but I think right away, they're large stones, they're moderately radiopaque, they're smooth. These are probably struvites. So this is probably going to be a dog that we want to try and dissolve them anyway. But just the idea being, even if there's a low number of stones, if they're really big, that's still going to be prohibitive in terms of getting them out minimally invasively. All right, I hope this will work, but this is what I'm going to do. So if I have a couple of medium-sized stones or a few small stones or what have you, whatever indication it is to use the laser, this is what we're going to be going in and doing. And what's nice is a lot of the lasers nowadays will actually kind of dust these stones, so you can see that that's mostly what's happening. But then there's these little fragments that'll break off that then I will have to go in and retrieve. So depending on the type of stone, kind of how it's formed and how dense it is, sometimes it'll just turn to dust. Other times we'll create these fragments that you're seeing created now. It's really satisfying when it works. And in this case, you can see I'm holding on to it with a basket behind it. But I showed this one because, okay, so this is just one stone. I think there's probably 5 or 10 more left in here. Sometimes it looks easy. Other times it takes a really, really long time just to create the tiniest little fragment. So this is me messing around for a very long time with the final payout being that. And then I still have to go in and get that. So as you can imagine, if there's a lot of big stones and I'm having to do that repeatedly, at some point it's going to be time and anesthesia prohibitive. I'll briefly talk about urethral because they're almost always problematic. Obviously, they're emergent if they're truly obstructive. I think what's important to remember, though, is that a lot of dogs at some point are going to leak around the obstruction, no matter how big it is. I see this a lot. And so even if they're leaking, it doesn't mean that they're not obstructed because they still probably can't form a full stream and there's still a lot of back pressure. Again, we're usually going to be using a combination of vascular retrieval and laser lithotripsy. And same idea, females have to be big enough to accept the scope. Males, same idea, but with an 8 French red rubber. That's the size of my scope. I think what's also important though is that I see this a lot, especially with like male intact dogs that have cystine stones that like to obstruct because they're so round. Lots of times I'll go in there, I'll get that one stone out, but usually then I'll drive up into the bladder and there's a lot left. So I always make owners aware that especially for some of these more radiopaque or radiolucent stones, I can relieve the obstruction, but sometimes the dogs are still going to need surgery after to get them cleared out. And I will say there's a pretty high risk for post-removal stricture based off of some of the studies. I think this is going down because a lot of us are using prophylactic NSAIDs. But there is a higher risk for post-removal obstruction when the obstruction is occurring at the same location. And it's almost always just proximal to the os penis in males where they get obstructed. And so there's kind of this acute narrowing, like where the penile urethra begins, and that's where they like to go. That's where they like to get lodged, and that's where that tissue likes to proliferate. Think of a picture of that. This is kind of just a classic case. I think this was a cystine stone that we were able to just go in and grab and not have to laser. But then sometimes they've been sitting there for a long time. So this is still us looking at a urethra. I lasered through parts of the stone, but you can see it's really deep. There's a lot of really pissed off tissue surrounding it and behind it. And then this picture on the right here, once I removed this stone on the left, I went back and there's even more proliferative tissue and more stones lodged in there. So it can be really challenging if there's either a lot of stones or if there's a lot of trauma. And that usually depends on how long the dog's been obstructed. Again, it's our best shot, especially if we can't retropulse. But this is just me saying that sometimes I can't always do it. And so that's, again, very brief introduction to some of the means that we have now for addressing some of these stones. And so does anyone have any questions?
It doesn't look like it, and I don't see anything in the chat. So I think oh, what is the typical cost?
Oh, good question. So that's what I'm actually trying to work with my hospital with and kind of with you guys with. I think for simply the anesthesia and the stone retrieval and laser, we're looking at around 3,000. But that I think it gets even lower if all the pre-anesthetic lab work is done and all the imaging is done. So again, usually it lands between 2,500 to 3 if I don't have to do more diagnostics like those radiographs, like the UA, like pre-anesthetic blood work.
Okay. Oh, also, is there anything new in treating CKD in cats? What is your opinion of porpoise one?
Course one. So that's a whole
Okay, I
other
was like,
conversation.
I'm gonna
Yeah.
mess that up. Sorry.
And I have a CKD lecture and I can probably do one for you guys at some point. But I will say briefly, porous one, I do very much like. I think it's a great way to get water into these cats. But there's so much new stuff with especially feline CKD right now that I think that's a little bit beyond the scope of this particular lecture.
How long do you give diets to work before moving to the next step?
So generally, if we're talking about diet and stones, we're talking about dissolving struvite. And there are studies to say that as long as the owner is actually giving the appropriate antibiotic as recommended, and it's strictly on the diet or the dissolution diet, you should see a response in size within 30 days. And so if I see that response in size within 30 days, or usually at the 30-day mark, you'll just keep going. And you should technically be treating with antibiotics and diet for the entirety of the dissolution protocol. I think, if we get 30 days out and there's really minimal change or there's no change, the first question should be, is the management appropriate? So is the owner actually giving the antibiotics and actually feeding the diet? But in a scenario where they are and the stones just aren't shrinking, it's usually about a month out that I'll decide to do something else about it. And I think we'll see a lot, especially with the struvite stones or the dissolvable stones, I should say, is that sometimes they have different layers, right? So sometimes maybe it's a struvite shell, but then there's a calcium oxalate core, or sometimes there's a carbonate in there that can be UTI associated, but they just take a really long time to dissolve. So that's a long answer for usually I'll give it a month. And if there's not a significant reduction in size, then that's when I'll start considering something else.
Okay. The next question was, is your fluoroscopy up and running?
It is up and running, and I am eager to use it more.
Yeah, let's go. Um, Dr. Daniel was wondering if she can call you and ask some CKD questions directly.
Yeah, of course.
Okay. Do you worry about bacterial resistance with the duration of antibiotics?
Thankfully, that's not something that we run into. And for whatever reason, for a lot of these struvite stone formers, they're not forming, these bacteria aren't becoming multi-drug resistant unless there's been kind of a wimpy dissolution protocol previously. But what we know is that as the stones dissolve, they are going to be shedding bacteria. And if we're not treating it or if we're not bathing that bacteria that's being shed, they're just going to form more stones. So it is kind of a rock and a hard place situation, especially from like a antibiotic stewardship standpoint, but this is the one scenario or one of the few scenarios where we are more comfortably and widely recommending just long-term antibiotics until they resolve.
Okay. The next question is, what is your opinion on grain-free diets in cats? Are they more or less likely to cause stones?
Yeah, that's a good question, and there's been some debate about this recently. And honestly, I don't really know yet. I think in terms of like the indications of grain-free in general, they're fairly low. But especially with because most of these cats are going to be calcium oxalate formers, right? And I think what we know better is that especially in cats, it's probably less dietary related and more just based off of their calcium handling at their renal tubules from a genetic component. So that's me hedging a little bit because I don't think I know enough about that specific topic to answer the question well. But I think for most of these cats, they're going to form it regardless of what diet they're on.
Okay, thank you. That looks like it's the end of the questions in the chat. So let's move on to cats.
Great. All right. So getting into cats now, it's going to be a very similar format as the last one, with a lot more focus on the upper urinary tract stones. I think this one was a little bit shorter. So again, same idea. Um, The big difference in this slide is that males, unfortunately, were generally unable to scope male cats. There is a like semi-flexible rigid cystoscope, which I do not have. I'm not that upset about because male cat urethras love to tear when you do try and scope them. I can definitely scope a larger female. Kind of same idea as dogs. If they're greater than 5 kgs, I'm willing to try. But again, for whatever reason, that tissue is just really friable, and so I usually avoid it if at all possible, especially pulling stones through it. And so for nephroliths, again, we're really addressing only problematic nephroliths. And I get, again, a lot of referrals for cats with kidney stones. And I wanted to say this in the last lecture, and I'll say it after this point, but we do have studies to say that nephrolithiasis does not affect the progression of CKD in cats. So a stone being there, if it's not obstructive or not problematic, that has nothing to do with whether or not their CKD is going to progress or if they're going to develop CKD. Obviously, that's not the case if they develop an AKI from obstruction, but I think that's just important to note. The other thing that I want to mention before I forget is I get a lot of questions, and I think owners tend to Google this, about shockwave lithotripsy. That is something that can be potentially recommended for some of the upper urinary tract stones and nephroliths. As far as I know, there may only be one place that's doing it right now, and I think that's Purdue, and I don't even know if their unit is working. There's a lot of what's the word I'm looking for? Reasons why it doesn't always go as well as we would hope, and that generally has to do with how hard cat and dog calcium oxalate stones are and how much space around the stone you need for the shockwave to work. But yeah, I just wanted to mention that because they didn't have a slide on it. And so again, we're going to address them if they're problematic, which means they are obstructive, painful, or causing infections. And again, it's kind of a soapbox, but I used to argue with my surgeons about this at NC State all the time. Just because a cat or dog is not azotemic or hyperkalemic does not mean that they're not obstructed, especially if they have a healthy other kidney. In fact, it's even worse if they are azotemic because that tells us they've got CKD in both kidneys likely, and that just means it's even more of a race against the clock. Generally, we're not going to recommend dissolution of feline nephroliths though, and that's because greater than 90, and I think maybe even greater than 95% of feline upper urinary tract stones are calcium oxalate, so we're just not going to be successful in dissolving those. You can attempt dissolution if there's a high suspicion for struvite. Again, I think I've seen struvite kidney stones like a handful of times, and even still there was question surrounding if that's what they were, if they were compound. But again, if there's really high suspicion, it's worth a shot. But in this case, in contrast to dogs, we're generally recommending surgical subplacement if they're obstructed. We do offer subplacement at AVES, so we have, I think, at least 2 surgeons that are willing to do it, and with our fluoroscopy unit, we can do it pretty well. We just did one the other week and it went great. I will say there's some caveats that I don't think are necessarily things that need to be walk around knowledge, but there's discussion, there has to be discussion surrounding the ability to place the sub, and that has a lot to do with the anatomy of the cat and how obstructed they are, and we'll talk more about this. And so same idea with uroliths, address if they're problematic, they're usually problematic. Same idea for what we're looking for to determine if they're problematic, and then same idea with medical management. But again, if they're obstructive, we're going to place a sub. And I think what gets a little bit difficult is that if there's not significant pelvic dilation, it can be challenging, if not impossible, to place a sub. And I mentioned this in the last lecture, but there's a high incidence of complications with stent placement in cats. And so that's the other reason why not only they develop the sub, but why we place the sub.
Before you move on, will you explain what a sub is?
Yep, I'll show you guys pictures in just a second.
Perfect.
And so this is kind of a classic kidney that's obstructed, right? And maybe not the most severe one that you guys have seen, but I think it's clear, right? We see significant pelvic dilation. I think this is probably like 7 or 8 millimeters. The renal architecture is a little messed up, and very clearly there is a reason for urine to not be flowing. But what we're seeing more and more is that sometimes a fully obstructed ureter can look like this. And so this is like maybe 2 or 3 millimeters of dilation. And this cat did indeed have an obstruction. And that's when it gets a little bit dicey. And so there's lots of caveats about this stuff. And so ureteral obstructions, especially in cats, can be dynamic. And that's usually because they're pretty small and they're round. And to add insult to injury in regards to how confusing it can be, is that as many as 80 to 90% of feline ureteral obstructions are partial. And we know this based off of ureterogram studies. And so sometimes I think that's almost definitely why some of these cats will have minimal ureteral or minimal pelvic dilation. And then that idea that I brought up in the last lecture, this idea of intra versus extrarenal pelvis, where maybe some of these cats just have more renal parenchyma surrounding their pelvis, and because of that, there's less room for the pelvis to dilate, even if it's obstructed.
Dr.
Um,
Slead, real fast, how will you know if the kidney stones are obstructive? Are we looking for an enlarged kidney on X-ray?
That's a good question. And so, yes, sometimes that can be helpful. But usually, again, we're going to have to use ultrasound or some other sort of advanced imaging to really figure this out for sure. So in a cat that maybe does have unilateral renomegaly, that should be your first clue to say, okay, let's go and look at the renal values. Is there a relative increase? Are they truly azotemic? Is there a relative hyperkalemia? If any of those things are on the list, and especially if the cat's painful, then it needs to go and have an ultrasound. And then that's kind of where, the radiologist or I will take over and say, based off of the combination of these clinical signs, hopefully we'll have fitting ultrasound changes that I talked about earlier, like hydronephrosis, proximal ureteral dilation, and periureteral inflammation. All of those things together will help us decide if it's obstructed or not. But again, this is why I wanted to have this slide, because it's not always that simple, because sometimes the obstructions are partial and you're not going to see those ultrasound changes, or sometimes they have a completely functional other kidney, and so you're not going to see that azotemia. But what I think is important to remember in terms of why it's important to get this diagnosis is that we have studies to say that after even 2 weeks of a partial obstruction, they're going to lose 54% of their GFR. So 54% of that renal function. And in a cat that's already 30-40% likely to develop CKD, we want to avoid that. What I think is also difficult, both in cats and dogs, is that there are really no reliable prognostic indicators to know what renal function is going to return to. So again, say we have an obstructed cat that is azotemic, we have no clue where it's going to go back to unless we had renal values from before it was obstructed. And sometimes it can take as many as 150 days after the obstruction is relieved before we know what their return to function is. And sometimes it can take that long to return to complete normalcy. And that's really with any acute kidney injury, which again is another topic for another time. But all the more reason to make this diagnosis, relieve the obstruction, and then give them time and lots of monitoring to figure out where they're going to plateau at. There are studies to say that once we start reaching greater than 7 millimeters of pelvic dilation, it's almost definitely obstructed. But there are now studies to say as little as 4 and I think even 3 millimeters of dilation have been associated with obstruction before. So again, that's the idea that, sometimes maybe everything is screaming obstruction, but when we image them, there's just not that pelvic dilation that we'd like. And that's in 25% of cases. So about 25% of ultrasounds for diagnosing an obstruction are going to fail to diagnose it. And so that's another case where I'd say, let's get out the fluoro unit, let's do an antegrade pyelogram, and let's definitively diagnose. Antegrade pyelogram has 90, nearing 100% diagnostic sensitivity to diagnose an obstruction. And there's even studies to say that like less than 5% of those cases will have any sort of complications. And so if there's a question, that's kind of what we turn to now. And again, we're set up to do that at AVES if there is that question. And so here is a sub. So sub stands for subcutaneous ureteral bypass system. This is actually the original sub, but the idea remains the same. And I'll show you a picture of the new one in a second, where we have the subcutaneous port, and then we have tubes going into the kidney and a tube going into the bladder, with the idea being the urine that's created in the kidney now has another route to bypass the presumed obstruction somewhere in the ureter. This is a surgical implant, so my surgeons will place that, not me. I will help sometimes. But it is something that we offer, and it is the recommendation for obstructed ureters, and that's primarily because for cats, most of them are going to have some degree of stricture formation at the site of the ureteral obstruction, and most of them are going to keep forming stones, because I'm sure, as you all know, we're so bad at preventing calcium oxalate stone reformation in cats. And so this allows just another means of that bypass if more stones happen. There are studies now to say that as much as 30% of these cats that do have a ureteral obstruction and a sub will at some point unobstruct their ureter, which some people would argue is a reason to not place a sub. I would argue it's nice to have two paths of urine flow. But for the sub placement itself, generally these guys are going to be in hospital for just a couple of days. I'll usually flush them at the time of discharge and then again a month later. And then we'll do it every 3 months after that. And so the flushing itself does require specific equipment and a specific solution that I will instill to kind of help prevent infection and incrustation. But I think that's probably the biggest conversation that I have with the owners is that once we have the sub in place, even if everything goes well, I'm going to have to see those cats pretty frequently. That being said, this isn't different from the recommendation of any CKD cat to be restaged every 3 months. And so again, I'm going to see them the same amount of time. I'm just going to do a little bit extra to make sure that the subsystem is patent.
Dr. Slead, we had a question in the chat. Let's see. Any information or thoughts on the IDEX cystatine? I'm going to mess that up. Cystatine B urine value for AKD.
Okay, yeah. So cystatin B is that's also something I will probably talk about in a CKD lecture coming up. It is good for differentiating active tubular injury because that's one of the few places that cystatin is when those renal tubular epithelial cells. So it's a really good diagnostic to figure out if there's an active acute kidney injury occurring. And there's even some studies to say that at least dogs with an increased cystatin B in like early stages of CKD are more likely to progress into further stages. I think we're still figuring out exactly what to do with it, but it is a good adjunctive diagnostic, especially in these cases where we're trying to figure out how acute the injury is. So I think it's great, and it's only going to get used more. But going back to subs, the pros and cons are kind of what you would expect, right? So the pros, there's less risk of reobstruction because there's another way for urine to flow, and generally they're going to have less lower urinary tract signs than stents. The cons is that it is a surgery, and there's about a 20% risk of infection, and about a 10% risk of device occlusion. I can usually address both of those. It's not fun or easy, but there are risks for having an implant in place, as you can imagine. And then obviously the routine follow-up, that's supposed to be another bullet point. I'll try and make sense of this. It's kind of confusing because it's a 2D image, but this is actually the sub 3.0. And so it's the same idea. We have this subcutaneous port, but in this case, there's only one tube coming off of the port and then entering into the abdominal cavity. And then everything connects at this Y connector. So this is coming from the port over here, and then this tube is going, I think, into the bladder, and this other one is going into the kidney. This is kind of a game changer because one of the other risks with sub placement, at least for the sub 2.0s where there's a port coming off of each side, is that a lot of those subs were kinking. So we'd find that the tubing system, especially when a cat lopes, the tubes, especially entering into the abdominal cavity, would kink, and then that would create an obstruction in and of itself. So with this new device, as far as I know, there's no reports of kinking. And this is the one that we're using. So really what we're dealing with in terms of risks after placement are what I just talked about. So infection, mineralization, stuff like that. Thankfully, no kinking. Moving to cystolis, this will be a shorter part when compared to the dogs. But generally, we're going to recommend removing them if they're associated with clinical signs. And then the same idea. So experience, the equipment you have, the urolith burden, and then we're going to remove them if they're more likely to cause an obstruction. Same idea, we're going to monitor if they're non-clinical or unlikely to cause obstruction. I think a lot of these cats are pretty clinical for these stones just because their bladder mucosa is so apt for inflammation. Cats are probably less likely to have struvite stones, but even still it does happen. And so we are going to try and dissolve those if we have compelling clinical evidence that they are struvite. And then again, the minimally invasive procedures are associated with shorter hospitalization and fewer adverse effects and residual stones. In this case, though, minimally invasive procedure encompasses and doesn't include the same things in dogs. So like I said earlier, we're probably not going to be scoping male cats to get these stones out. In general, Females are going to be a little too small even still. But we do still have options, and the biggest one is a PCCL, which I'll talk about in a second. This again is the same table from that Vet Clinics of North America study that I think is just a good resource to refer back to. And then I'm always willing to talk about these things too. So the PCCL is a percutaneous cystolithotomy. And basically it's kind of a combined minimally invasive or like endoscopic and surgical procedure. And basically what it is a tiny little incision into the abdomen that allows us access to the apex of the bladder. You then basically cannulate that tiny incision that we make, and we use saline irrigation to distend the bladder. And then I'll put my scope and I'll put the stone retrieval basket through that trocar and cannula and remove them that way. This is really nice for small animals, so not only cats, but also dogs, and really doesn't have many limitations. It's also just good for when we don't have other means for retrograde access. There was a recent study that came out comparing a PCCL to cystotomy, and probably not as many differences as I think a lot of people would hope. So there's not a big difference in surgical time, not a big difference in anesthesia time, and so far no significant difference in complete removal. But this actually can be an outpatient procedure because the incision is so small. So we've done a couple of these, and they get out of the hospital quick. And again, you can barely even see the incision when we're done with it. So this is an image of what it looks like. So again, they're going to make this tiny little incision here, grab the bladder with a stay suture, insert the trocar, and then we can insert our scope and grab the stones this way. In addition to having less limitations for size, there's also less limitations for size, the size of the stone. So even though it's a small dog or a small cat, we can usually get out pretty big stones via this because the cannulas are a lot bigger. Urethral or urethral obstructions in cats, again, kind of a whole other mostly critical care lecture to give. But again, generally they're going to be problematic. Lots of them will leak around, and we're usually going to prefer hydropropulsion into the bladder. So then we can either remove them surgically or with the PCCL that I just mentioned. Again, large females may actually still accept the scope and allow for me to break them up with the laser in the urethra and retrieve them that way. That is just kind of the minority though. And that is because, like I mentioned before, there just seems to be a high incidence of iatrogenic trauma in cats. Their urethras are just a lot more wimpy in terms of the tissue and it being likely to tear. What I will also say, and this is just kind of an aside, is that lots of these cases, even ones that are going to be retrograde or retropulsed, a stricture is likely, and especially males, and especially those that have a stone stuck for a while. And because of their anatomy, it's really easy to diagnose a stricture if you have a contrast study. And so I think that's always something to just think about when maybe we've relieved an obstruction, a urethral obstruction, and then they're still having symptoms, but we can't find a stone or a plug. And so with that, I will take questions.
There's nothing popping up in the chat at this time, so I have taken over the screen again. Thank you, Dr. Slead, so much for presenting. This is a QR code if y'all don't mind scanning it. We really appreciate any feedback. Oh, wait, sorry, pause. Dr. Slead, before you sign off, can you discuss Tamsulosin?
Tamsulosin. Yep. So basically the same type of drug as prazosin, but technically it's supposed to be more uro-specific. So it's supposed to target those alpha receptors specifically in the urinary tract and potentially be less likely to cause the hypotension that could theoretically be caused by prazosin. So I just prefer it for that reason. There aren't actually any studies comparing if it's better or worse than prazosin, but just physiologically and in humans, that's kind of what they reach for.
Okay, thank you. Okay, I don't see other questions at this time. So again, for everyone who has attended, this QR code will lead you to a survey. It's just, I think, 6 questions, asking for your feedback, about how we did on this presentation, what you need moving forward with other presentations, how we can serve your hospitals. So please take just a few minutes to fill that out and send it back to me. Um, and that would be very much appreciated. Thank you all for coming. And if there's anything else, please reach out. Again, my email is Christina with a CH .bingham@austinvets.com. And Dr. Slead is Dr. Slead, SLEAD at austinvets.com. Thank you, Dr.
You go.
Slead.
Yeah, always feel free to call and email me about this stuff too. I love talking about it. So if there's ever a question, give me a call.
Awesome. Thank you guys. Good night.
Thanks.